been a collaboration between the Stroke GIRFT and Oxford AHSN teams with support from the British Association of Stroke Physicians. We've had more than 220 people register for this event with a good representation from healthcare professionals across the patient pathway. We have 3 short presentations followed by a Q&A panel session. We will pick up some of the questions posted in advance during the panel discussion which follows the presentations, and you can also post more questions during the webinar using the chat function. Just a reminder, we are recording this webinar to share after the event, and it will be available on our respective websites. Okay, so I'll introduce our first speaker, Rob Key. We're delighted that Rob has shared with us his experience as a patient admitted to an NHS stroke service during the pandemic. Rob will be known to many of you as the former Kent and England batsman who is now a familiar face on Sky's cricket coverage. We will play a short video of Rob interviewed by David Hargroves, the National Stroke Lead for GIRFT, who you will also hear from shortly. Just a few slides of introduction from me about the 2 publications we produced. The first was at the peak surge phase of the pandemic, and we produced a guide on adapting stroke services during that period, which covered implementing telemedicine, delivering safe stroke care when there was patients at hospitals without stroke units, and using virtual clinics for managing TIA and minor stroke. The guidance we've just released now is for the restoration and recovery period of the pandemic, where we've looked at assessing the effect of changes, how to support colleagues and keep staff safe, focused around the patient and carer experience, reducing the spread of COVID within the stroke pathway, and what the clinical pathway should be for patients with COVID. And also more broader issues of how to maintain standards within the stroke pathway and look at supporting cardiovascular prevention in the community. We've used a framework throughout the guidance developed by the RSA, which looks at things that have been started during the crisis which we should end, things which we should amplify because they show signs of promise for future service delivery even after the pandemic is controlled, things we have to stop that should be restarted, and then ways of working which we can now stop completely and let go. And there are various examples of this for different parts of the pathway throughout the guidance. We are also calling for case studies. A lot of the guidance is based on learnings from units that they've fed into us, but shared learning is more important than ever at the moment. We would really welcome other case studies, people describing solutions people have developed from across the whole of the stroke pathway. And these are submittable to the resource hub on the BASP website. So my introduction to Rob was a little bit early, but I won't repeat that. So we'll now play the interview with Rob.
If I'd been asked to go to a hospital that I'd heard or read in the papers, or I mean, I'm on social media, which is just a minefield for stuff. And if I'd, you know, if it had been somewhere that I might not have come, yeah, that might have. It wasn't until, I mean, that was almost the first question we asked the 111 service was, is this a COVID hospital? And they sort of said, no, you're fine. So for me, it was then actually better than any other time I'd been in A&E before, you know, with a broken finger, whatever it had been, because there's no one there.
With regards to the difference you experienced for nurses and doctors interacting, you wearing the masks, so did that cause you any anxiety? How did you feel about that?
Having nurses and doctors wearing the mask wasn't a problem for me because that's what I expected, really. And because you sort of, well, what's going on with COVID? Is this, you know, and they're constantly reassuring you, and you realise that they're wearing it for you as much as anything else. That didn't bother me. It's like anything in life, I think. It all depends. You know, whether someone's got a shield on, gloves, whatever it is, the manner is everything. So the lady who looked after me, who was working the nights, was so good. It didn't bother me what she had on. Now, had that been someone that was not like that, it might have been a different story. But because, you know, regardless of all that stuff, that human interaction was absolutely key for me. The hardest thing when all this was going on was that I couldn't see my wife or my kids. My kids are 13 and 11. So, I mean, it's a mad thing, but I suppose when you hear this diagnosis, you don't know, you think the worst. And ironically, I didn't really have much care for myself. I was more just thinking about, oh my God, my kids are going to have to deal with this. But that, without question, was the hardest thing. I mean, you feel so alone in hospital when you can't see your wife or whoever it is. I mean, you know, this whole process, I'm so lucky that I have that. And that's made me very grateful to have someone there that I can be with. But at that point, that is the biggest change. Yeah, but all the protective gear, all of that stuff is nothing really compared to not being able to see my wife or have someone actually there just to say, you know, whether it's to hold or whatever it is you want. Just, you know, and when I got home, like the relief was massive. Because I felt like I was fine, I could move, I had everything was going on. You know, so it was quite nice to speak to someone a week later, and I'd say, oh, you know, I feel a bit tired. Oh, that's normal. Great. This is normal. That's normal. And I said, just be careful though, because you're more at risk, which is that's the balance. I think we sort of know that. For me, I know that. I don't need that constant reminding. And also, what does that mean? You know, what's that, 90%? You know, am I 50% chance? You know, is this going to happen tomorrow? Are you talking about in 10 years' time? Are you talking about with pills, without pills? You know, what does that mean? But what it does to you as a patient, it makes you think, oh, here we go. You know, so you could be having a good day and you could be thinking, yeah, no, you know, I'm feeling fine, anxiety's down, and straight away that puts you in a bad place. And that's all from then on, you know, that's always I feel, and I've never felt this, you feel so fragile to things. You know, someone rings you, I had someone ring me the other day and said he'd had a stroke. How you going? Yeah, no, I'm good actually. And then they'd say like, yeah, just be careful. And you think, yeah, thanks for that. You know, and that's the same with the doctors. You know, people become like your life almost, where you're just hanging on every single word they say. That's what I felt. You know, I ring my GP and it's like they can change your mood from depression to like that with just the odd thing, and that can go both ways. You know, that I found it's a mental game now, and I found that the most important thing.
Well, we really appreciate Rob for that perspective on the patient experience during the pandemic. And Rob is going to be joining us for the panel Q&A discussion, I'm very happy to say. Next speaker presentation is from David Hargroves. Many of you will know, consultant stroke physician and clinical lead for the GIRFT stroke program, who's going to cover the pre-hospital and acute end of the pathway.
So thank you very much, Gary. And just to echo your sentiments, we're really grateful, Rob, for you recording that video, but also joining us for the panel discussion. Some really helpful insights. So the document that we have produced together covers the entirety of the stroke pathway regarding pre-hospital through to rehabilitation life after stroke. I've just picked up on 4 key areas that I'd like to focus on with this webinar regarding the acute aspect. And I'll cover each of these 4 aspects over the next 10 minutes. Next slide, please. So the backbone of great healthcare is our staff, and this is particularly important across the stroke pathway. Many of our teams have performed exceptionally well regarding the surge phase, but they are not as resilient as we would like them to be, and therefore we need to think very carefully about how we sustain our team members over the next year to 18 months, as realistically that is how long we are going to have a prevalence of COVID in our communities in the NHS. Using the four boxes that we had highlighted in the guidance, looking at how we end certain things, let go other practices, amplify certain things that we've been doing, but also restarting certain aspects. This also applies to staff wellbeing and workforce. There are many new ways that we have learned to engage with our staff during this pandemic and the surge phase, and we need to be consulting them now and thinking about how would they like to be communicated to, are we going to ensure that we allow everyone to have their holidays, their study leave, the governance aspects of a good stroke service. All of this needs to come back to function fully over the next year to 18 months, and careful planning is really required. Individual risk assessments are an absolute must, and we know there are certain groups working in our stroke pathway that are at greater risk, and there may well be ways of working that are particularly specific for those individuals. And at-home working via telemedicine or with regards to governance may well be a certain aspect of their particular work. Next slide, please, Hannah. Thank you. So with regards to standards of stroke care, we have been fortunate in the NHS, if we look at SNAP data, that's demonstrated our processes of care during the surge phase were not significantly hindered. Now, a lot of that is to do with the flow, in the sense that we have had less admissions, at its peak, maybe 20% less admissions, and we were able to discharge patients quicker. And therefore, we found access to some of our interventions in stroke care had not suffered. During the restoration and recovery phase, however, that may not be as easy, because we will find that, and we're almost there with regards to our stroke numbers now, and discharging may not be as easy as before, and therefore access to the 10 key standards that I'm going to talk to you here with is vitally important. So the pre-hospital phase, thinking about introducing telemedicine, and we've got pilots going in the east of England, north central London, and also in East Kent, demonstrating that between 40 and 50% of patients can actually have an alternative destination other than coming to the HASU. And that may well be vitally important over the next year to 18 months if we're going to sustain our services. We know getting an earlier a senior decision-making assessment, getting your brain scan very quickly is vitally important, but we do have to realise that the efficiency of our scanners may not be as we would previously like, given the cleaning that's going to be required. It's not just thrombolysis and thrombectomy that we need to make sure we can continue. There actually hasn't been any reduction in thrombolysis rates over the surge, but we have seen a reduction in thrombectomy. We need to make sure that we reduce anticoagulation in patients that bleed, but also blood pressure, as well as we would with regards to ischemic stroke. Next slide, please. Admission to the stroke unit. So we know on a public health benefit, that is the most important intervention we can all make, is ensuring our patients get to a multidisciplinary 7-day-a-week staff stroke unit. And again, SNAP data is suggesting that it's 15% more likely to get to a stroke unit within 4 hours during the surge phase. But again, that may not be achievable once we have the increased number of patients we're expecting once we get back to a normal incidence. Swallow screening is vitally important, as we know, and we must take into account the adequate PPE that our staff require when they're undertaking the swallow screen. We also need to make sure that we minimise the amount of time that patients spend in hospital, but we do not delay discharge awaiting COVID screens. It's very important, however, that whatever environment our patients are going to are protected and are aware that there may be a pending COVID result if you don't have the rapid PCR RNA test. TI clinics we covered in the first document, but again, there may well be a need to continue some virtual assessments going forward to prevent the nosocomial spread, but also those high risk groups of patients who may still not want to come back to hospital. There's a schema that we've included in the document which highlights those 3 groups of patients that you will commonly see in this next period. So those that are very highly suspicious of having COVID, and those what should be managed in a COVID specific area. Many of the stroke services in England have tried to put these patients in side rooms on the stroke unit. What we're advising is that there must be locally agreed infection control so that you really do limit the chance of nosocomial spread. And we are suggesting that these are COVID-specific wards within reaching of the stroke MDT. Rapid testing is actually most important, we feel, for those patients that you don't think have COVID or actually have an indeterminate risk of COVID, because those patients, once you have a low clinical probability and a negative test, can go to your normal HASU care, and therefore we should prioritise potentially those patients. All of our patients, regardless of their COVID status, should have access to those 10 key standards that I mentioned previously. With regards to the next, or the potential for the next surge, if you remember in February and March, the NHS has 100,000 beds, and we were preparing for 4/5 of those to be required to care for COVID. Now, the reality was we only ever needed on any one day 19,000 beds. Therefore, our preparation was vast compared with the actual need. Going through the next phase, however, with the restarting of many of our elective work, we may not have that luxury. And therefore, we almost require more detailed planning whilst we are continuing all the other activities that go on within a hospital if we do get a local regional surge. And therefore, it's important that one communicates with their teams now exactly how you are going to coordinate your team. And we may have to accept that some of our team members may well have to go to help with the COVID response. I think I'll stop there and we'll have some questions at the end. Thank you.
Thank you very much, David. Our third presentation is from Rebecca Fisher, Stroke Association Senior Lecturer at the University of Nottingham, and also Rehabilitation and Life After Stroke Workstream Lead for the NHS Long-Term Plan.
Thank you, Gary, and good evening, everybody. So this is what I'm going to cover, focusing on inpatient and community stroke rehabilitation. Next slide. So I'd like to start by saying something about the ethos on which we've developed this document, which for me reflects some of the positive ways people have responded to the COVID crisis. This document very much represents the tenacity and support of all the staff in rehabilitation teams working on the front line and people supporting them in a network or commissioning role. We started weekly community rehabilitation calls at the start of lockdown, chaired by myself and attended by representatives from across the country. Dr. Deb Lowe, our National Clinical Director for Stroke, has attended each one, and it's through those calls that we've gathered the information covered in the document and that I'm presenting today. I'd also like to say that collaborative working is something that has shone through during the crisis and that definitely needs to continue, not just across the country, but also between clinicians, managers and academia to support, evaluate and sustain improvements in stroke care. It is important that stroke specialist rehabilitation beds and dedicated stroke therapy areas are protected as part of stroke unit care, as there are stroke survivors who need rehabilitation in hospital. If this has changed as part of the discharge to assess process, this needs to be addressed, as stroke specialist rehabilitation is still required. I've been really impressed by stroke therapists who have worked really hard to maintain intensity of rehabilitation on stroke units whilst wearing PPE and adhering to infection control. It's important that stroke patients who have been moved to other wards during COVID also benefit from stroke specialist rehabilitation, and teams have worked out ways to achieve this, including training and support of other staff. Flexible working introduced during COVID has a benefits in increasing therapy availability at weekends, and where possible this should be amplified. I've also heard many regions mention improved communication across acute and community elements of the pathway through virtual meetings, which again should be maintained. So now in the restoration and recovery phase, it has been really reassuring to hear that many community teams have returned to providing stroke specialist rehabilitation in the community. There's been real concern for patients who have been put on waiting lists or who never presented, who were discharged very rapidly. And I know teams are working really hard to follow these patients up. It is important that expansion of service criteria, for instance, teams seeing a larger patient caseload or patients with high levels of disability, and the move to 7-day working is appropriate resourced and commissioned. There's been lots of discussion about decision making on delivery of face-to-face therapy. I know staff and teams have felt under a lot of pressure and have had to deal with high levels of ambiguity. It's really important now, though, that patients who need and want to be seen are seen, while also adhering to infection control and safety procedures. There are some examples of great decision-making tools that teams have created to help with prioritisation and managing of risks. The example that we feature is from Berkshire. There's also detailed regional guidance from South Yorkshire and Bassetlaw and Greater Manchester and other regions. I know that teams are really concerned about family members and caregiver wellbeing too, and are working with the voluntary sector to support them. The psychological adjustment of returning home and living with a stroke is huge for stroke survivors and family members, and even more so now. There's been lots of discussion about access to care homes by community teams to ensure care home residents receive rehabilitation. And this was a big problem initially, but seems in some cases to have been resolved thanks to the tenacity of staff. I've mentioned it already, but one of the key benefits, particularly of adopting virtual methods, has been better communication across organisational, discipline and geographical boundaries to break down barriers and facilitate joint working, for instance, between health and social care. I will mention the Stroke Association services in the next slide, but just to say the Connect service, offering a phone call to stroke survivors, is a great opportunity to help stroke survivors and their families feel supported as part of a wider stroke care pathway. I must also mention the Royal Colleges and Societies, who have done a fantastic job making sure members are fully supported. So telerehabilitation has received a lot of attention, so just some key points. There are lots of resources and information out there, some of which might feel overwhelming to staff. A group of us have developed a stroke community hub to provide some core resources and guidance to staff, which we hope is helpful. There have been some real trailblazers and early adopters, for instance, South Yorkshire and Bassetlaw and Northampton, with some fantastic webinars. I know that the national team are mindful of the fact telerehab may not be the answer for everyone, and we're keen to work with teams to address potential inequalities. There are still teams struggling with shortage of hardware, which needs to be addressed. On the plus side, teams are getting to grips with various platforms, such as Attend Anywhere, and collection of routine data is really important, including mode of contact, patient outcome and experience measures, because this will help with evaluating telerehabilitation over the longer term. Regions of team are keen to share learning around 6-month reviews. It's so important that the needs of stroke survivors who are discharged early are reviewed, and also that all patients are reviewed. Online groups and peer support has also been flagged up, and I know that there's some really innovative work being conducted by the London Queen Square team focused on group telerehabilitation. There are also opportunities for stroke survivors to contact each other virtually, for group or socially. And I must also highlight all the great work by the Stroke Association, which offers some fantastic resources and support for stroke survivors and their families. And there's a slide with the web links at the end. So to summarise, we need to look after each other and be mindful of well-being. Psychological support is really important at this time and needs to be resourced. Staff have had a lot to deal with, particularly with regard to decision-making for delivery of face-to-face therapy. And this document and other guidance and tools are designed to help with that. It's also really important that stroke specialist rehab is still provided in hospitals for those who need it. Telerehabilitation does offer a lot of promise, but does need to be evaluated. This needs to augment face-to-face therapy with appropriate PPE and a blended approach for stroke survivors. And lastly, let's continue and maximise the spirit of collaboration. I would like to thank all the people who helped with this document and all the staff who are working tirelessly to provide rehab and support for stroke survivors and their families. So thank you.
Thank you, Rebecca. We'll now move to the panel discussion following the 3 introductory presentations. I'll briefly introduce our other panel members joining myself, David and Rebecca. So first, delighted that Rob Key is able to join us. We're also joined by Professor Rustam Salman, consultant neurologist and president of the British Association of Stroke Physicians, Deb Lowe, consultant stroke physician and national clinical director for stroke medicine, and Dr. Guy Rooney, medical director for the Oxford AHSN, who provided valuable perspective and input into the guide from a non-stroke senior clinical perspective. So we're going to start with some of the questions posed in advance, and then we will move to questions posted in the chat function if you post them there. So please do feel free to use that. We've received more than 30 questions in advance, so I can't promise we'll get through everything that's been asked, but we'll do what we can to, plan to finish at 6 o'clock. So I suppose I'd like to start with a question to you, Rob, if I may, about when you were in hospital, how did you manage to communicate with your family? I'm assuming they weren't allowed in at that point, and how did you find that?
Yeah, so I have an iPhone, so I was just able to FaceTime them and all of that. And I was unlucky to have it, but lucky in the fact as well that, you know, I could speak, I didn't have any issues. So, and for most of my time in there, I didn't think there was anything wrong with me. So I was more sort of annoyed at having to be in there. So I was able to chat fine, really. And then when I obviously found out that I'd had a TIA, I then, you know, I'm slightly, a hell of a lot more panicked, but still being able to use my phone and stuff and speak regularly. And the other is little things as well, like the nurse Charlie had a charger because my phone was going to run out. So had that, you know, had she not had that, then I would have been sort of for a day without my phone, which is, you know, unthinkable if I wasn't struggling with illness as well, to be honest. So that was a massive bonus.
That's really interesting, Rob. I think we're all familiar with the nightmare of having no charger for your iPhone, and of course none of us would think to be carrying around an iPhone charger in case we happen to have a stroke when we get to hospital. So that's something we can all easily provide, is iPhone chargers to our patients. Great. Deb, maybe I'll put this question to you. How will the stroke priorities within the long-term plan be reframed in response to the learning from COVID and the future challenges we may face from further waves of COVID?
Thanks, Gary, and welcome everybody. So it's been obviously a really extraordinary time, but out of many crises you see real innovation and acceleration of adoption of pathways that the things that we've always wanted to be doing, and there were many priorities within the long-term plan that have been accelerated during this past 3 to 4 month period, and I'll allude to certain things. So we've been trying to get data linkage for a long time between SNAP and HES data, the hospital episode data, so we can understand a little bit more about stroke activity and people's concurrent illnesses, comorbidities, and stroke admissions. So that's been accelerated, which is really positive. There have been lots of other silver linings and innovation that we've seen around ambulance triage pilots, accelerated packages of care so that appropriate discharges could be made very rapidly, protected stroke beds at times, but not across the piece, which was quite frustrating. Virtual clinics have obviously been accelerated, virtual rehabilitation that Rebecca has alluded to. I think the biggest thing that we've seen that's been a real positive is the stroke community has come together in a way that we've never experienced before, and that's across acute providers, community providers, commissioners, the NHS England teams, and also voluntary sector and patient to public voice, and also Royal Colleges and British Association of Stroke Physicians. So that's been a positive, that people have started communicating really closely with really excellent local leadership, shared network, shared learning, so that we're not reinventing the wheel because someone's usually done something already and first. The long-term plan priorities have been repurposed. So we've just had a stroke board this afternoon actually, and we've been going through our priorities very clearly today. And the one area that's deteriorated slightly over the COVID period is activity and access to thrombectomy. So we've made a commitment today to understand why that happened. There are lots of confounders that may have resulted in that, but we're going to do a real focus on accelerating adoption of thrombectomy across the country, but also rehabilitation and life after stroke care. Many more people are much more isolated now than they have been. There's a big psychological mood and cognition burden post-stroke that needs even more attention. And there have been some pilots, for example, with the Stroke Association around Stroke Connect to try and mean that people aren't isolated and alone in the way that we know that they are going to be during this really difficult time. And there's been a suspension, obviously, within NHS England of a lot of the budgets at the moment, but we've been able to guarantee that we've got maintained budgets to progress the integrated stroke delivery networks. And these really are the delivery models that we need to deliver against all of our timelines within the long-term plan. So lots of opportunities. It's been a difficult time, but within England, we've managed to maintain delivery of acute stroke services across every single unit in the country, which is a huge just congratulations to many of the people that are on the call that have managed to enable that was delivered.
Yeah, thanks, Deb. That's a really helpful overview. And interestingly, there was a question just come up in the chat about why was there a reduction in thrombectomy? So it's good to see we'll capture some learnings from that and hopefully not have a problem with that when we get any second phase. I've got another question on information governance and data security, which I'll ask Guy to comment on. The questioner says, IG and data security took a back seat during the emergency, but now it's reasserting itself. And what are the implications of this for some of the methods of clinical interaction that people have introduced during the pandemic?
So just as a brief explanation, in a previous life, I've been both a medical director and a Caldecott guardian. My learning from that was there are two types of information governance officers. The ones who say, no, you can't, and the ones who say, you can't do it like that, but you can do it like this. So my biggest tip is find the second kind, because they will help you get through the sort of sometimes the apparent quagmire of the no's. No one relaxed the law. The law is there, and you would be prosecuted if you broke it. So I don't think there's been a relaxation of the law. I think what people have been doing is they're moving more towards solution focus and actually finding ways of working within the law, but actually helping people. I would just encourage people to drive that forward.
Great, thanks, Guy. I mean, certainly this was, there's not much positive about the pandemic, but we did see some of the barriers to implementation of digital innovation become less problematic. David, a question on guidelines. Where do the RCP stroke guidelines fit in with the new normal ways of working? Do they cover the way we're working, or are they going to need a rethink?
So thanks, Gary, and very interesting question. So of course, the most recent RCP guidelines were 2016, and they were due for a refresh. And so they will be hopefully in the next year or so refreshed in light of with our experiences of COVID. So at the moment, the core principles of stroke care should be maintained. And so I think the straight answer to that question is they still are warranted and valued, and there isn't anything in the 2016 guidelines that we would suggest has changed during the COVID pandemic. It's just, it may be more difficult to deliver them. And if we think about the NICE guidelines from last year, 2019, we were already struggling within the stroke fraternity to deliver particularly thrombectomy, which we've alluded to, and MRI access for both TIAs and for our minor strokes. And so I think those two, access to MR and access thrombectomy, are likely to be the two areas that are most challenging for the stroke community to deliver over the next year to 18 months. And again, so we talked about systems. It's about early communication with the relevant partners, both within your hospital and outside, to work out what is essential, what is your efficiency of access to imaging, and what is a luxury that in fact you might not be able to have during the very difficult next year to 18 months. Thanks,
David. We've got a question which I think was an important question pre-pandemic, but remains a really important one during the pandemic. There's a few, Rebecca, and it's, what are your views on intensity of therapy and completion of individual goals in a stroke survivor with a moderate stroke who's keen to progress? So, how should we be thinking about that in the context of the pandemic?
Yeah, it's a really good question, and particularly the point about moderate stroke survivor, because I think these are the stroke survivors that we really need to be thinking about and focusing on, particularly as they've been potentially been discharged early into the community. So I think there are issues because many teams have not been allowed to potentially go and see these patients, even though clinical reasoning deems that they should be, and particularly as those patients potentially would have, especially going on to the severe, would have 2 people going out to see them. I think where possible, teams have managed to now, with the support of trust, convince people that it is important to provide intensive rehabilitation to avoid the loss of rehab potential. So I think, yeah, it's been challenging, but you know, we need to consider issues around devolving spasticity, people that potentially were walking or aides were walking in hospital and then have deteriorated, and obviously mood as well. So, and lastly, as I said in my presentation, the transition between hospital and home is huge. So that we do, you know, staff do need to see the patients if they need to be seen with the appropriate PPE.
Yeah, thanks, Rebecca. We've got a question which certainly as an academic interests me. I'll put this to Russ Dan. And the question is there a danger that the new ways of practicing we've established become norm without evaluation? And so I guess the challenge is, you know, how should the researchers and the research system be responding to the changes we've seen?
It's a great question. And I think out of adversity often springs innovation, enthusiasm, novel ideas that could really successfully contribute to how we deliver stroke care in the future. The challenge is to wrestle with the long proven fact that things that appear to be common sense don't always turn out to be best for services or patients in the future. So we need to be really careful to be innovative and progressive, but temper our enthusiasm for those things, recognizing that sometimes innovations really, especially where there are patient safety and economic consequences, they really require evaluation. So it was really gratifying in the COVID pandemic in the early stages to see such a rapid response from funders to fund COVID related research and prioritise it as well. But as services restore in stroke medicine, so too does stroke research. And I think we as a community need to get behind stroke research that's responding to the COVID pandemic, not only to understand the interaction between COVID and stroke, but also to get behind projects that are perhaps evaluating in a really helpful way rapidly some of the changes in services that are suggested. So I think there's a real opportunity for us to continue to work together to improve stroke medicine in this new context, which is not going to go away anytime soon.
Yeah, I mean, I think it is a real opportunity, certainly for the sort of service pathway type research for us to look at. And one thing I think, you know, we really also need to think about in this is understanding as you mentioned, the patient experience as well as the sort of, you know, straight clinical outcomes, because we've really not had an opportunity to capture that during the pandemic very well. Maybe that's a supplementary question to that, to you, Rustam, and maybe others. Are there any of the changes you've seen that have happened during the pandemic that you would highlight as areas we should look at evaluating very early on?
Thanks, Gary. So, I mean, the first thing I saw in the pandemic as a result of this really great communication that everybody the need for communication that everybody responded to so quickly, was actually that some things that are supported by evidence that we've been doing patchily in the past, that we suddenly had the opportunity to embrace because there was a need. So enhanced delivery of telemedicine, for example, which has got an evidence base to support its safety, which many places weren't using, and now more of us are. So first off, I think that there was a catch up with what was already evidence based. The second opportunity now is to look at things like artificial intelligence, which are always deeply alluring and attractive when they're multicoloured, user-friendly, phone-based, sexy, dare I say it, and where we assume that they're going to improve care. And often when there are commercial interests in these products as well, we need to be careful to evaluate them fully first. So I am really most in favour of harnessing the opportunity to rapidly evaluate these things now before they are approved for widespread rollout and the rabbit is out of the box and we're not able to put it back in and evaluate it properly.
Yeah, I mean, one of the challenges now, Jen, is how we do evaluation without formal research frameworks for innovation that comes in, where the researchers haven't got to it yet, and yet we still need to do that. So I think that for us is an opportunity. That actually leads into another question, which I'll ask David to answer, which is, what is the national strategy for instant image sharing in stroke thrombectomy? And related to that, is AI going to be a blessing or a curse for the future of stroke services in the UK?
So thank you, Gary. And Rustam, I concur entirely with your thoughts regarding evaluation. We know that the most efficacious intervention we have in stroke medicine is thrombectomy, and currently 1.6% of our patients currently get it. So we need to improve that, and 50% of our patients that do get thrombectomy get it because they live in the local community to the neuroscience centre. So the image sharing issue is very, very poignant. And on the GIRFT visits, we picked this point up, that the delay in transfer of images and the lack of ability for real-time communication with the interventionalists at the hub centres was one of the cited causes for concern. It was also the lack of access to CTA, 24 hours a day was the other reported challenge. So there is a hope that artificial intelligence will be a decision support aid. And I think it's really important that we make the distinction between true AI, which is autonomous, and a decision support aid. And for those of us who've been using advanced imaging for a decade, we're not expecting the AI to actually give us an answer that we wouldn't have come up with from reading the scans ourselves. What we are hoping, however, is that it shortens the pathway. So as opposed to me looking at a perfusion scan that takes 25 minutes for the radiographer to sequence and then send it through to the PACS, AI may well be able to do that in a couple of minutes. So we're hoping that it won't just be the selection of patients, but it's the time and the communication with a web-based solution, which may have the real advantages. But I agree entirely with Rustam, we do need to evaluate it, which is why, of course, plug here that we're working with your group, Gary, to evaluate the implementation of AI within the Titan network, but also Southeast Coast, to assure ourselves that it does add value and not to just get attracted by the pretty pictures.
Yeah, thanks both. We had a question, and it's been partly answered in the chat function by Deb, which was, has the number of stroke patients for the same period of time last year increased during the pandemic? I mean, I think we have very clear data that the number of stroke admissions declined, and Deb's answered that in the chat, by 20 to 25% during the peak surge period, and that was seen in other countries across Europe. And we do know at least that a lot of that was people with minor stroke symptoms were less likely to present. We're now back to normal levels. There may also have been difficulties of patients who had stroke who were care home residents getting in. We don't know the answer to that yet. But there is a question about, does COVID increase the risk of stroke? There are some data out there. I don't know who wants to pick that up, maybe Rustam. And I suppose there's two bits of that. There's the just having COVID in the early stage increase your risk of stroke. I think we know later on that stroke is a complication of severe COVID disease. But Rustam, do you have any comments, or anybody else on that issue?
So I think, sadly, for the big epidemiological questions, we're still looking for the answers. As far as service use behaviour goes, as has been noted in the chat, we do have some useful data, most recently from UCL, I think, showing that the admission profile of major stroke to severe stroke was really exactly the same before and during the early phase of the pandemic. But it was minor strokes that tended not to present to hospital. I think there are some data sources that are hinting that there might have been increases in some types of stroke, and of course anecdotal case series of the strokes that we've seen, especially ischemic strokes, that seem to follow an unusual, more prothrombotic mechanism. But I think that the the most reliable epidemiological data are yet to come. I know Deb is aware of some data in this domain that she's discussed before, so she may want to share.
I mean, thanks, Rustam. I mean, certainly within the published Office of National Statistics data, we know that there was an excess death rate in people's own homes and care homes during the COVID period, with people registered as having had a stroke as their primary diagnosis. Now, many of these patients never had a head scan, didn't attend hospital, so the exact nature to the increased mortality is unclear at the moment, so there's a lot of work going on to look at that. We know that COVID predominantly affected older people, but also ethnic minority groups, and there was an increased risk with diabetic patients as well. So we know that the biggest risk factor for stroke is getting older, so the increased incidence of COVID and stroke maybe have co-founders around age, obviously, along with the other CVD mortality risks. But loads more analysis at the moment. There's lots of study groups at the moment between the British Heart Foundation and others looking specifically at the big data, the big epidemiological data. So we'll have more answers in the coming months.
I mean, I thought it was really interesting in Rob's video interview where he talked about, one of the first concerns, having had a minor stroke, TIA, was, is it safe to go in? And then he asked that question. Rob, if you're picking up all this technical stuff we're saying, I'd just be interested in your comments about what do you think the stroke community and healthcare system should do now in terms of communicating, that if you've got a fast positive stroke symptoms, you think you're having a stroke, don't be afraid to come to hospital. What do you think are the sort of things that would make people feel comfortable that we need to do?
It's tough, really. I suppose it depends on what you follow. If you're on social media, what sort of scare stories you believe in, where you are with. I mean, for me, what made the difference for me was the 111 call. So my wife rang them, and as I said, the first thing we asked was about that, and they said, no, go in. I think that's the absolute key, really. I suppose we live in a world where it's very hard to promise things, but when they said the fact that where I went didn't have an ICU, so it wasn't a COVID hospital, it was everything. I mean, as I say, I might not have gone in had it been the other way around. And then I suppose it's down. I didn't really know what happened to me because I've always suffered from migraines. So I was very close to just putting it down to that. How you get that message out there, I suppose it's tough, really, because we live in a society now where there's so much scaremongering about everything. But for me, that 111 service was absolutely vital, and your GP as well, because I'd imagine some people would go into your doctors or call them now, and then they're the people that, when you know not very little about anything, you turn to the experts, and it all depends on the message they're sending, I suppose. I
mean, it does seem to me we need to have clear non-COVID stroke and TIA pathways for the vast majority of patients, and also rapid assessment of, obviously, the people excluding COVID infection, be it asymptomatic or symptomatic on presentation. No, thanks, Rob. I think it's a really key point we need to think about. I know in Italy, they ran a whole public media campaign with stroke specialists going on sort of TV saying, it's safe to come into hospital.
Yeah.
So, yeah, certainly something to think about. A few more questions coming through. Very technical one, maybe for David and Rustam to comment. Should we be considering using tenecteplase instead of alteplase, given the available evidence, and if we have a second wave, this will help differentiate the thrombectomy? So we know the trials are ongoing comparing tenecteplase to alteplase. Views on this?
Shall I pick up on that?
Yeah.
You go first, Rustam.
Thanks. I mean, I can really understand it, and it's a great example of the sort of thing I was talking about earlier, where we've got, in this case, not a technology, but a drug that's really appealing because it's just a quick shot. The nurses love it. There's no infusion to monitor, and it's so appealing as a potentially non-inferior or equivalent thrombolytic to alteplase. You know, in some countries, tenecteplase is cheaper than alteplase. There's the convenience that we talk about. And on the basis of the existing evidence, and as Gary says, there are many ongoing trials that are probably more relevant to our sort of question, it appears to be at least as safe and effective. The problems for its immediate use now, out of convenience, are that it's not licensed for stroke in the UK. There's only limited evidence that it's non-inferior to alteplase. We haven't fully sorted out the dosing. You know, the trials explored many different dosing regimens. And also there's obviously no option to interrupt the dose. That's the convenience of it. You can't stop it like you can an alteplase infusion. And I suppose the other practical concern for places that are already not particularly familiar with tenecteplase and might be using it for the first time is that the drug packaging that's used for tenecteplase in the UK is for myocardial infarction. And the myocardial infarction dose is different from the dose that's been tested in some of the tenecteplase trials for stroke, where we're still trying to find the right dose. So it's just like I said earlier, share the enthusiasm, would love it to work, but I don't think it's ready for prime time just yet for those reasons.
Yeah, thanks. I think the only comment I would add, and I have to declare a conflict of interest because I'm part of the trial steering committee for the ATTEST trial, is recruit people into the studies and let's get the answer and let's get all the research recruitment going. Yeah.
I knew you'd say that, Gary, which is why I didn't say it, but I agree with you.
So I'm not behaving myself as chair. Rebecca, a question on outcome measures. It says, what are your thoughts around outcome measures as we're using more telecare services in the community? Which seems an important question. How do we assess the impact if we can't do outcomes which might have traditionally required more physical examination?
Yeah, really good question, and definitely, as I said in my talk, important that we keep collecting outcome measures. I think the teams that I've spoken to have actually continued to complete standardised measures with a combination of telephone, video or face-to-face contact, which is very encouraging. There are also some versions of measures that can be used more or designed to be used remotely, and we've backed up research evidence to show that they can be as effective or still valid. I think there are issues around other measures like the bag balance and safety issues around that, but still teams are working around it. So I think on the whole, I think we should definitely still continue. Yeah,
great, thanks. Question to Deb around the use of digital platforms and consultations, and being used in different ways all across the pathway. And the question is, where do we see the greatest opportunity for use of digital platforms in the stroke pathway to benefit and support reduced resource of consultants, nurses and AHPs? So, and I think it's a really important question, how do we use digital to increase workforce productivity?
Yeah, thanks. I mean, I think it's across the pathway. It starts pre-hospital, certainly with some of the examples around pre-hospital triage. So South East and London have been piloting, and East of England, even pre-COVID, have done some excellent work looking at reduced conveyance of patients with appropriate use of digital platforms for tele-remote assessment with stroke nurses and stroke consultants. Certainly, as Rustam alluded to, the use of digital platforms within A&E to reduce recurrent patient contact. If there's someone that's suspected as COVID, if we do get this second surge that many of us are worried about, but I must note that it looks like that's probably going to be a local geographical surges over the winter period rather than a whole country second surge. The use of virtual clinics, not for all patients, so we can't just go lock stock to virtual clinics, and most services now are reverting back to face-to-face for patients that's felt to be most appropriate. But certainly for follow-up patients, it seems a useful tool. But again, I was just typing in an answer there around the digital inequalities question. So many people either don't have devices that they can do video calls, because the video element is really quite important for many people to get that connection rather than just a telephone follow-up. So making sure that we have a community that is digitally enabled is really important, so that we don't make the health inequalities that already exist even more stark. And the follow-up element, we've fallen flat really with our ability to deliver 6-month reviews and ongoing review and follow-up. And there's a very clear arena here for using this much more widely with not only virtual platforms for follow-up, but also our virtual rehabilitation. But again, evaluating things and being very clear that it's not just us as healthcare professionals, because it's convenient for us and we think it works, we carry on doing it. So including our patient and public voice in any of our decision making about ongoing evaluation is so important.
Thanks. Question for David. What developments do we need in pre-hospital services in the context of the pandemic?
So we've touched on this regarding the pre-hospital video consultations that are being piloted in those three areas of the country, and some of the preliminary results that do demonstrate that one can have an alternative destination in between 40 and 50% of patients. So this is great news for patients if they don't need to come to hospital and they can be managed virtually. Also, if it is more likely they have another condition, which means they can go to the local ED and not bypass to go to the HASU. We will be evaluating the paramedic response, because one of the challenges we found with this adoption prior to the pandemic was there was a degree of concern from paramedic colleagues about whether it would delay transfer of patients. So of over 450 consultations within the South East Coast and London North Central, the mean communication time is 5 minutes. Therefore, and this is when the ambulance is stationary, so it isn't thought to significantly deleteriously impact the call to leaving scene time. But again, further analysis needs to be done and evaluated to really understand what the benefits are. But I would, yes, so watch this space. Hopefully in the next few months we'll have some evaluation results for everyone.
Great, thanks. I'm going to ask one more question to my fellow clinicians, and then take the last question for Rob. So this is, if there is another peak, how can we prevent stroke services being closed again? And there's a specific question about that for local flare-ups. So maybe Deb and David, your thoughts and reflections on how you should respond when you either have a local flare-up or we get into a second return surge phase of the pandemic.
I can jump in, and I'm sure David will want to follow. So I'm hoping that the original document that we supported at the beginning of April around managing the acute surge phase will be a go-to reference for if you do have another local surge, how to address that. I think it's really important that we learn the lessons and the things that may not have gone well from the first surge period, and that may be around making sure that we are cohorting and separating our COVID possible suspects, our patients separately. And that is around really rapid testing at the front door. So all stroke patients, we've been working with the regional teams to try and encourage that there is, for all stroke patients that present, rapid antigen testing to try and enable patients to go to the right hospital ward as soon as possible, and not mix patients that may be COVID positive with patients that have had negative swabs. I don't know if you want to add anything else, David.
No, only just to add, Deb, and thank you, Gary, is that this next phase is going to be more difficult because our presentations are likely to be back to normal. And one of the things that and Martin will be talking about next week at his SNAP webinar regarding the data, small changes at each end of the pathway allowed us to have more beds. I don't think we're going to have that in the next year to 18 months. So the rapid testing and organisation is going to be even more important for the next year and 18 months, even more so than the initial surge, I think.
Rebecca, Rustam, Guy, any comments or reflections to add? No?
Just it's been, I'm just checking the chat, the endorsement about evaluation more generally around telerehab augmenting face-to-face therapy, so I endorse that.
Great. Okay, well, thank you, everyone. If Rob's still available, and maybe a challenging question, but whether you had any final comment from your perspective on what you think is the most important issue or topic stroke services should consider during this phase.
I found my time in hospital pretty good, to be honest. It was all, I was in for a couple of days, and it was good. I have found the hardest thing is after that, when you're at home, and you know when you're in hospital, you sort of know there's blood pressure machine, there's all these things there for you that if anything happens, you'll be all right. When you get home, you realize that's not there. And then it's the follow-up care afterwards. As I said in that video, you're just hanging on every word of a GP or one of you guys, whoever you're lucky enough to speak to, because it's not always easy to get hold of people. It can just, your mood can just go, in either direction. So that follow-up care, whether it's through a Zoom call, I had the cardiologist test, when I had the heart test, that was through 2 Zoom meetings with the cardiologist. I actually went up to have the various tests, but they were like, they were great moments almost for me to, when you hear, oh, this is fine, this is what you can do, this is what you can't do. So I found everything since is when the real challenges come. And that's, for me, has been the most important thing.
Thanks. That's a really helpful comment, actually. I think one of the things the pandemic has done is almost exacerbated problems or highlighted problems we had already that were very difficult. And I think that the issue of follow-up of people after discharge has been an area that's been often highlighted by patients as something we could improve. And I think it was competent presentations, that transition is something we need to think about. So I'd like to thank all the webinar participants for joining, and of course our speakers and panelists, particularly Rob, for making the time to join us. And also I'd like to thank those who submitted questions, and obviously, unfortunately, we were unable to answer all of the questions. I've yet to do a webinar where we don't have some technical hitch, and those of you in the webinar won't have noticed the technical hitch other than me getting my words in the wrong order. Classic Eric Morecambe joke, they were the right words, they're just in the wrong order. But unfortunately, we had expanded the capacity of a number of participants to above 100, but you have to switch on a crowd function, and it wasn't switched on by our administrators. So some people couldn't get into this webinar, so popular it was. But I'm saying this because hopefully many of them will have a chance to see the webinar with the recording we're going to put on the AHSN and BASP websites and GIRFT websites. So with that, thanks again, and I'll close the meeting.